Immunology of blood transfusions and transplants. First, we're going to start with blood transfusions. Once you're done with the immunology course, your next quarter is probably going to be blood banking, or what we call immunohematology. So you've taken the two hematology classes, and then we're going to throw in some immunology, then we're going to bring it all together with immunohematology. So this is a small introduction to that piece. Well, blood transfusions is where we look at the hundreds of different erythrocyte antigens that are assigned to numerous different blood groups. Right now you're familiar with A antigens and B antigens, right? There's many, many more. There's hundreds more that you're going to learn about how those work in the blood banking or immunohematology course. We're going to look at the clinically relevant ones when you get there, but let's just take a second and look at what the importance of that is. Well, the ABO blood grouping is characterized by different carbohydrate moieties attached to certain glycoproteins and glycolipids on RBCs. What does that mean? This just tells you that different blood types have different antigens on them. Please don't memorize this slide specifically, but it does tell you this, that there are a lot of specifics that go into play with this. O people don't have any of those antigens on them, so they're considered a universal donor. A has A, B has B, AB has A and B antigens, and O doesn't have any. Anybody can get type O because there's no antigens on it of immediate significance. Next, we'll look at the RH blood group, or the D antigen. This is what makes you A pos, B neg, A neg, etc. It's the positive and the negative piece. So this is the most dramatic effect we see in hemolytic disease of the newborn. We're looking at something called a D antigen. If you have it, you're considered Rh positive. If you don't, you're considered Rh negative. I am O positive, so I do have the D, okay? Now, there really is not a naturally occurring antibody to the D antigen. People don't just have it. What happens is, I'm O positive, and if I were in my mom's belly and my blood were to leak out from me into my mom's Rh negative, she'd start making antibodies because her body has never seen my Rh positive cells before. So this is where we have something called hemolytic disease of the newborn. This is where mom's cell or baby's cells somehow migrate into the mom. That's not a normal occurrence. And the mom will start making antibodies to the baby's blood. Well, unfortunately, babies, those IgGs can cross the placenta. So the antibodies that the mom is making to the baby's blood cross the placenta and attack the baby's blood. So it's a very unfortunate circumstance that that we treat with something called RhoGAM. So you may have heard of people saying, oh, I got the RhoGAM shot. So we give moms an anti-IgG antibody shot to make sure that they don't produce it and cause this to happen. So if you are Rh negative as a mom, you get this RhoGAM shot while you're pregnant and just before you, right before you have the baby as well. And even after, to make sure that you don't develop those antibodies and harm a future baby. So how do we determine your blood type? Well, we take and we mix your blood with antibodies to anti-A, to anti-B, and D. If agglutination occurs, that test is positive. So if anti-A antibodies agglutinate with type A cells, it's positive. Same thing with B. If both, then you're type AB. If neither, then type O. The results with the D tell us if you're Rh positive or Rh negative. So that's a little bit about how that works. Next, we're going to talk about solid organ transplantation. So that was blood transplantation. What about taking Sally Sue's kidney and giving it to Kelly? Okay, what's going to happen inside Kelly's body once she receives that kidney? Well, we have to look at the histocompatibility antigens in each patient. Okay, Kelly has different ones than Sally Sue. So when Kelly receives Sally Sue's kidney, Kelly's body's going to say, wait a minute, that's not my kidney. And it's going to create antibodies against her kidney. It was fine when it was in Sally Sue because Sally Sue's old major histocompatibility complex for those human leukocyte antigens are known as self. Well, once it hits Kelly's body's going to say non-self, non-self. So it's going to start making antibodies to destroy this foreign material. So This transplanted tissue triggers a destructive mechanism we call rejection. And if the recipient cells recognize that major histocompatibility complex protein products on the cell surface, it calls them foreign. So the laboratory evaluation we do, we look for HLA typing to make sure that Sally Sue's kidney will be a good fit for Kelly. We text both of them for HLA typing, and we want to make sure that they are as close as possible. So let's look at solid organ transplant. How long are people on the list for this? It depends on their blood type, their tissue type, height and weight, the size of the organ, the medical urgency, how long they've been on the list, how far are they from the hospital, how long will it take to get there, how many donors are in the area, and there are transplant centers criteria as well. We have different terminology for these transplants. We can do an autograft, which is taking skin from one area to the other on your body. So for example, if you're a burn victim and it's on your face, they may take some skin off your booty and they'll put it on your face, for example, just to, from person to person. You won't reject that because that's your own skin. So it's the best case scenario right there. Another one is a syn graft. This would be to a monozygotic twins. So this is a identical twin. This will always work out if they are identical twins, okay? That's a syn graft. An allograft is a graft between a genetically different recipient of the same species. So this would be Sally Sue and Kelly. Sally Sue gives Kelly her kidney. That is an allograft, okay? Human to human. An isograft is one identical twin to the others. This is similar to a syn graft. And a xenograft would be like an animal to a human, like a pig heart valve or something to a human. Lots of different things can be transplanted. Kidneys, heart valves, heart, corneas, skin, liver, lung, pancreas, even bone. In order to protect yourself from this rejection process, there are certain medications we can use, and we did cover a lot of these in clinical chemistry too as well. Cyclosporine is immunosuppressive. Corticosteroids can inhibit the antigen-driven T-cell proliferation. Tacrolimus, also known as FK506, is 100 times more powerful than cyclosporine, and this inhibits the T-cells and interleukin-2 to stop that destruction from happening. And another one called sirolimus. One thing we have to watch out for is graft versus host disease. Now, what can happen in the case of Sally Sue and giving Kelly her kidney is that the person that we're giving the organ to, the actual T cells in that organ can turn around and attack the person, but also the person's T cells can attack, so the Kelly's kidneys T cells can actually hurt the donor. So we have problems with that as well. This is more common in bone marrow transplants. Okay, we see rash, fever, lesions, multiple organ issues. The donor's limbs recognize the host as foreign. So you're giving somebody a bone marrow transplant, but that bone marrow transplant is actually trying to kill the receiver. So it can be a very dicey thing to deal with. They really have to take and destroy the immune system of the person receiving the bone marrow before they can get the new bone marrow. We'll see increased CRP and SUD rate with that if this does occur. So we really want to irradiate those blood products. We don't want to give someone blood products where those T cells could attack the person that you're trying to help. Some of the factors that we see with rejection, we can have a hyperacute rejection, which is very quickly. That would be like giving a type B person a type A kidney. I mean, there's all kinds of issues with that. Accelerated, so 2 to 5 day, is when that would come in. Acute, 7 to 21. Chronic is over 3 months, and immunopathological damage could be over 3 months where we see immune complexes. We do have some biomarkers for rejection as well. So they've been studying concentrations of this messenger RNA or proteins that are associated with the immune activation or tissue stress to see the effect with this rejection. We also have something called a FOXP3 messenger RNA, and that can predict reversal of acute renal allograft rejection. There's very high sensitivity and specificity with that one. All right, so let's look at this bone marrow transplantation specifically. Now, a lot of people know or have heard of somebody who have had a bone marrow transplant. The goal of transplanting bone marrow or peripheral blood progenitor cells is to achieve a potential cure from people who have had some type of leukemia. They'll go in and kill off all of their bone marrow and try and give them new bone marrow, just to keep it simple. The cancers they can treat with this are leukemia and non-Hodgkin's and Hodgkin's lymphoma. So what are those progenitor cells that we're talking about? Well, these have the ability to evolve into many different types of cells. Some are peripheral blood stem cells, and the CD34 antigen identifies a population of stem cells that can reconstitute hematopoiesis after a myeloablative chemotherapy. So let's put this into perspective. Patient has Hodgkin's lymphoma. They're going to give them extensive chemotherapy to kill off the bone marrow and cells that they currently have and give them somebody else's bone marrow. These cells are magical and will find a way into the recipient's bone marrow and grow into a whole new system. Okay? Hopefully, destroying all the old cells. A couple different types. We can have allogeneic. This is where a person receives peripheral blood cells from a relative or an unrelated donor that has a pretty close HLA match. We can have a syngeneic transplant, which would be from an identical twin. And we can even do an autologous transplant. This is donated from their own cells after a peripheral blood stem cell mobilization with these growth factors. Now, gosh, I don't know how often they do it anymore, but back when my kids were born, there was an option to freeze your cord blood. And if you freeze your baby's cord blood, they could possibly, if your child gets cancer later on, they could take and use that as a bone marrow type transplant. So what are the treatment options? Well, first there's chemotherapy to kill all the malignant cells. Unfortunately, it kills all cells, not just the malignant ones. They also use radiotherapy, which uses high energy beams to destroy cancer cells as well. Then they go ahead and do the bone marrow transplant. But the future directions we're seeing, there's better immunosuppressive drugs. We see new treatment programs with monoclonal antibodies directed right at certain antigens on those lymphoma cells. And there's also a myeloablative approach to chemo with a bone marrow transplantation that can be a lot less toxic. Well, that brings us to an end for this section.